Okay, so this is chapter 18. It is disorders of blood flow and blood pressure. So we're going to be talking a lot about vessels, blood vessels, and what happens in the blood vessels. So first of all, if we're going to be talking about blood vessels, it helps to know the structure. And particularly when it comes to pathologies, a lot of the diseases that we're going to talk about are deal with arteries. Okay, particularly we're going to talk a lot about atherosclerosis and some vasculitis. And so when it comes to really a pathology, we're talking about blood flow getting to something to distribute oxygen or something like that. Um, we're also going to talk about veins because there are some venous issues, but most of the time will be spent talking about our arteries. So if we look at the structure, look at this not as, oh, gee, here's an anatomical thing that we have to learn. Look at it more like, well, if blood is flowing through here, a lot of our problems are going to be involved in these inner layers. Okay, so like a vasculitis or something like that is going to involve more the inner layers, and like something like atherosclerosis is going to actually be something that's going to happen out here in this layer, and it's going to involve smooth muscle. So um, yeah, it's important to know the layers and know the names of them, but really we're interested in kind of keeping this mental picture of what the vessels look like. So the tunica externa is this outer layer. It's elastic. There's a lot of collagen, which is strong, and elastic fibers. So elastin is the protein. And and that's important because vessels have to stretch. So again, if we're thinking about the function and we're being practical about this, the aorta is getting a whole lot of blood under high pressure from the left ventricle, so it has to be able to stretch and it has to be able to push back to its original structure. So yeah, it makes sense that it has a lot of elastic fibers. Um, so tunica media is the middle layer, and it has a lot of smooth muscle. Okay, so remember, smooth muscle can proliferate. So things like neurons, we're born with all we'll ever have, for the most part. Same thing with skeletal muscle. We have as many skeletal muscles as we're ever going to have. Smooth muscle is different. Smooth muscle can proliferate. So you look at this inner layer, this middle layer, this tunica media, and you can see that it's made up of a lot of smooth muscles. And when we talk about atherosclerosis, these smooth muscles are going to migrate, and they're going to sort of surround those plaques. Okay, so that's something we kind of have to understand, that there's smooth muscle right there. They're going to be triggered to migrate around those plaques, and also some elastic fibers. So there's some elastic there's an elastic membrane here, and so those things are all going to contribute. And it's basically the blood vessel trying to sort of redefine itself or rebuild itself, even though there's this buildup of these plaques that are inside. And that'll make more sense when we actually talk about it. Um, but overall, the smooth muscle is there for vasoconstriction. Okay, so I mean, the muscle it's either going to constrict or relax. When it constricts, it causes vasoconstriction. When it relaxes, it's vasodilation. So it lets that lumen, or the lumen is just the opening, it lets that either get smaller, larger, or smaller. Okay, and then there's the tunica intima, which is this endothelium, the endothelial part, or the inner layer right here. Okay, and we want that to be, smooth and unobstructed, okay, which is actually what I've written right here. The endothelium should have a smooth surface so blood can flow without too much interruption. Okay, so that's what we're talking about, is the endothelium, this inner layer, and that's where exchange takes place. Food and oxygen pass into tissues from blood. Waste and carbon dioxide pass from tissues into the blood. And it also, and we've already talked about clotting, it creates compounds that stimulate vasodilation, vasoconstriction, inflammation, so the inflammatory processes, and like I just said, the clot formation. So the endothelium actually does quite a bit. I mean, it makes these factors. Von Willebrand factor is made there, and that's what we were talking about with the clotting primarily. Um, so it promotes vasodilation and vasoconstriction, but it doesn't actually have the smooth muscle. Now that's in the next layer out, that tunica medium. That's what has the smooth muscle for vasoconstriction, vasodilation. Okay, but it can affect that layer as well. Okay, so disorders of arterial circulation. Hyperlipidemia. Well, we know what hyper means. We know what lipids are. That's going to be an increase in fat. Okay, that's hyperlipidemia. That's this term here. Atherosclerosis, that's a little more specific. We're going to have to go through that step by step. It's a progressive disorder, especially when we're talking about atherosclerosis, and it can affect any artery in the body. Okay, so that's where we're concerned about it. It affects the arteries. And then we're going to mention a couple of pathologies associated with vasculitis, which causes direct injury of the vessel. Okay, infection, immune reaction, and it affects arteries. It can also affect veins and even capillaries. And then we're going to talk about aneurysms. Okay, and this is primarily caused from a weakness in the vessel wall. So again, we're talking about vessels. We're talking about a weakness that causes it to kind of balloon out or kind of push through that weakness. Okay, and that generally affects arteries or something that's under a little more pressure. Okay, so to talk about hyperlipidemia, we kind of need to understand what the lipids are and how they're moving through the blood. So a lipid is, usually some kind of a hydrocarbon, but if you understand anything about solubility, you know that hydrocarbons tend to be very insoluble. Okay, so they don't readily dissolve in water like something that is charged or hydrophilic would be. Lipids are hydrophobic, so they would, if you just dumped a bunch of lipids just as they are into the bloodstream, they would kind of all form like this bead and actually kind of get in the way. So that's not how they're moved through the bloodstream. They're actually moved on something called a lipoprotein. Okay, so that protein part of it helps to contribute, but it's actually the entire structure in general. So cholesterol. Okay, so when we're talking about lipids, we're talking about cholesterol, triglycerides, okay, fatty acids in general, and phospholipids. Okay, so remember, phospholipids are made, that's the main component of a cell membrane. And so cholesterol, triglycerides, and phospholipids are carried in blood plasma in a protein lipid structure called a lipoprotein, which are made of lipids and protein. So if we look at this guy, so here's a lipoprotein. Okay, so these are both lipoproteins, and they're kind of surrounded by these phospholipids. Now remember, phospholipids have a hydrophobic tail, the inside, and then a hydrophilic head. So the head likes water. So that's really, it's almost like a little cell all by itself, except it's not a bilayer or anything like that, and it's just filled with fat. Basically, it's filled with triglycerides, cholesterol. It's just filled with these lipids. But it is able to kind of exist in water or float around in water because it has this hydrophilic outer layer that's made up by these phospholipids. And that's really the main function of phospholipids, although the phospholipids are also carrying, fatty acids, so they can be used as well. So lipoproteins we're going to get into, and here's what we're talking about. Ultimately, we're talking about HDLs and LDLs. So we're talking about good cholesterol and bad cholesterol, but we have to know so much more about it. So lipoproteins are categorized according to their fat content versus their protein content. Okay, so if you look at this guy, it's got one protein and a lot of fat. So if proteins are more dense, then something with less protein and more fat is going to be less dense. Okay, so something that's got a lot of cholesterol, a lot of triglycerides is going to be way less dense than something that has more protein versus the fats. I hope that makes sense. Fats kind of are, when we're talking about density, we're just talking about, basically how much they weigh versus what size they are. And something that is very dense is, if you could think of like a dense cake or something like that, tends to be very, very heavy. Okay, so lipids are less heavy and proteins are more heavy. So that'll hopefully make more sense in just a minute. So if you look at a lipoprotein, Okay, made of lipids and proteins. Here you can see the proteins are kind of scattered out here to the outside. Now these proteins can work as signaling molecules. So um, one of the things that our cells need are fats, and our cells need cholesterol. Things like um, estrogen. Estrogen is made from cholesterol. So that means if we have a cell that's trying to make estrogen, it's going to need cholesterol. So that has to be carried around. And so, so you can see in here there are cholesterol esters. So don't worry about cholesterol versus cholesterol esters too much. Esters, if it's esterified, that just means it has a little fatty acid attached to it. Okay, that's all that means. And I'm not too concerned about it. I'm mainly concerned that you understand that it's carrying cholesterol to a cell, or it's carrying cholesterol from a cell. Okay, so that's what's really going to matter here. But you know, here's the structure of a triglyceride. You can see that there are triglycerides in here. And here's a structure of a cholesterol that's non-esterified, which basically means it doesn't have the fatty acid tail on it. Okay, so we have cholesterol and we have triglycerides, and then the whole thing is surrounded by these phospholipids. Okay. All right, so that's what a lipoprotein is. It's got the protein, and then it's got these fats that I just mentioned. So we want to. It really helps and makes it less mysterious if it all just sort of makes sense in some way. So when we eat a diet or when we eat a meal, there's a lot of fat in this meal. You know, it's going to have triglycerides in the meal, the food that we eat, and it's going to have there's going to be cholesterol. So these things have to be taken up. They have to be absorbed. And so immediately what your epithelial cells of your intestine do is they form this little thing called a chylomicron. Okay? And that chylomicron has a lot of the triglycerides. So the yellow here are triglycerides. So that's like 80 to 90% triglycerides, and then about 2% protein. And you can see there's a little cholesterol in there. And of course, the whole thing is surrounded by phospholipids. Okay, that's great. We just ate a meal, we got a bunch of triglycerides, we got a little bit of cholesterol, and now where's it going to go? Well, it goes to a couple of different places. One of those places is just straight to adipose tissue. It's like, well, this is triglyceride. You know, if as long as we have enough energy, then these triglycerides can pretty much be taken straight to the adipose tissue, and you can drop that off. Or it can go to the liver, and the liver can kind of process it. Or maybe the muscles need triglycerides. So these chylomicrons, even though they come straight in, most of them try to get to the liver as quickly as possible so they can be processed and they aren't just floating around in your bloodstream. Some go to fat cells. Okay, and some actually go to muscle cells as well. Okay, so they're absorbed by the intestines, and then they kind of go to one of these places. Well, once you've dropped off a bunch of triglycerides, this may happen in the liver as well. But once you've dropped off a bunch of triglycerides, then either usually for storage of some sort, then what you're left with is something that has, well, it kind of makes sense, fewer triglycerides. Okay, so we have fewer triglycerides and a greater proportion of cholesterol, and that's one of the places our focus is. And we also have a greater concentration of or proportion of protein. This is called a VLDL. But look at the VLDL; it's still largely triglyceride. Okay. So then this can again be taken. So if it was processed in the liver, then it may be sent off to adipose tissue, or it may be redistributed as well. Okay, but we just know that we see both of these things. We know they come in as chylomicrons, and then they will form these VLDLs. They're very low density lipoproteins, because remember, the lower density is going to be more fats. And so those have to be dropped off. And then when we've really kind of given as much of the triglycerides either to fat cells or muscle cells or whatever needs them, then we're left with an LDL. Okay, so look at this one. compared to the others. And what do you see? You see that we've just dumped our triglycerides. Triglycerides are gone. For the most part, there's still some there. But the triglycerides have been dropped off. Either the liver is going to process them, they've been dropped off at fat cells, which is usually the case, or even muscle cells. And what we're left with is cholesterol. Okay, so the LDLs now, those can go to cells that require a lot of cholesterol. Okay, those cells I was talking about earlier. These guys were pretty much just dropping off triglycerides, and now we have this lipoprotein that's floating around in your blood. I'm spending some time on it because it's an LDL. That's what we call bad cholesterol. Okay? And sure, it's serving a noble purpose. It's trying to distribute cholesterol. The trouble is, this is what can cause a lot of pathologies, namely atherosclerosis. Okay, so then it drops it off, or the liver also makes this thing called an HDL. Now look at the HDL. Look at that. It's half of it is made of proteins. Okay, so it's high density. Proteins are more dense, so it's a high density lipoprotein. It doesn't have nearly as much cholesterol, and what it's going to do is it's actually going to take cholesterol from the cells and then move it back to the liver. Okay, so it's saying, hey, we have too much cholesterol either coming from cells, or it may just scavenge it from inside the blood vessels. That's why we call this good cholesterol, because it's kind of picking up leftover cholesterol. Okay, so that's why we kind of tend to focus on these two. The chylomicrons and the VLDLs, those are in many ways, more nutritional. It's trying to distribute the fat. But what we've noticed, even though the LDLs are nobly trying to distribute cholesterol, we know that they can cause a lot of problems at the same time. Okay, so this is another, I'll go through this really quickly, I guess, but very low, and high density lipoproteins, so chylomicrons, again, made by intestinal cells, carry triglycerides to the adipose tissue, other cells, and then to the liver. VLDLs carry cholesterol and triglycerides made in the liver from the liver to the adipose tissue, so they're dropping off more fat, like I just kind of mentioned. Adipose tissue could go to muscle tissues, but it's trying to move those triglycerides around. When they're dropped off, it forms the LDLs, and the LDLs again are a higher concentration of cholesterol. Okay, and this excess cholesterol can collect on arterial walls, and then the HDLs. The HDLs are much more protein and much less cholesterol. So the darker orange here is the cholesterol. So it has not as much cholesterol, and more protein comparatively. And so that's actually trying to clean it up. Okay, and it's trying to so from cells and vascular membranes and transport it to the liver and maybe some endocrine cells. Okay, and then I have here estrogens can increase HDL as well as diet and exercise. Estrogen actually has a protective role in many things. Okay, so lipid transport in the body, same thing, just a different type of picture. This introduces IDL, which are intermediate density lipoproteins. I'm not really gonna talk about those, but that's kind of the intermediate between the VLDL and the LDL. Okay, your book mentions those. A lot of books don't even bring those up, but ultimately, what we care about are good cholesterol, bad cholesterol. And that's because really when we look at a lab result or something like that, that's really what it's going to come down to. That's what we're going to be looking at. The rest of those are important in terms of processing our nutrients, but the LDLs tend to be what are really bad, and those are what really cause a lot of pathologies associated with things like death. Because atherosclerosis can lead to heart disease, and that's what's really the problem, or that's what the problem really is. Okay, so low density lipoproteins, bad cholesterol, less protein, more cholesterol, leave deposits. Actually, they leave themselves, and they are the deposit when it really comes down to it, and we'll see how that works. as they take lipids to cells. High density lipoproteins, good cholesterol, more protein, less cholesterol, clean up deposits in the blood as well as removing lipids from cells. Okay, so research shows that the distribution of LDLs and HDLs is genetically determined, and that was a big problem because it used to be that we just checked cholesterol levels, and then we sort of started looking and saying, well, some people with high cholesterol aren't necessarily sick, and we've realized that they had more HDLs in their body, and then we showed that, and then we figured out that, well, some people, it didn't matter if they had a high cholesterol diet, they still had a lot of HDLs, these good cholesterols. And so it was sort of figured out that you're kind of born with either you're going to make more or fewer, and it is controllable by our diet, but largely it's also just genetic. And now if you just eat something that has a lot of saturated fats, yeah, you're going to have more LDLs, whether you're genetically predisposed or not, and vice versa. A couple of other things, these are seen as correlations. We don't necessarily know why, but levels of HDLs tend to be lower in diabetics. Okay, so they're still looking at a lot of the data, and right now we just see correlations because we can measure it without really knowing why that's the case. Okay, so hyperlipidemia. Well, like I said before, hyper means elevated, lipidemia means lipid. When we talk about hyperlipidemia, we're talking about all the lipids, okay? Elevation of any or all lipids or lipoproteins in the blood, okay? So that includes cholesterol and triglycerides. It includes HDLs and LDLs. So that's hyperlipidemia. The cause is independent, or the cause is independent. Let's see. When we're talking about primary, okay, cause of hyperlipidemia, it's independent of other secondary causes. So generally that's what we term when we say, okay, so that's genetic. You were just leaving more lipids in your blood for whatever reason. We'll talk about some of those reasons. Secondary, okay, so things that you do have control over, and you can modify this, or a client or a patient can modify this. Diet, they can modify that. Now, some of these others you can't necessarily. It's hit and miss. Some you can, some you can't. Diabetes, maybe not. Thyroid disease, same, maybe not. Renal disorders, liver disorders, obesity, maybe. Alcoholism, sure, yeah, you might be able to control that, but that's a whole other category, whether you can control that or not. But these things can all lead to hyperlipidemia as well. Okay, diagnosis relies on, we're talking about hyperlipids. We're talking about lipids, which means we're talking about all lipids. The proportion of each starting with a complete lipid profile. So we look at cholesterol, we look at LDLs, we look at HDLs, or total cholesterol. Okay, and then we look at the cholesterol associated with LDLs and HDLs, and then we look at triglycerides. Okay, so those are all the lipids that we're going to be looking at. The overall profile can provide information about the risk for cardiovascular disease. Well, hopefully you've already sort of seen where this is going to go. Well, if I have a high total cholesterol, but I've got a lot of HDLs, an abundance of HDLs, and not as many LDLs, I should be okay, right? And yes, yeah, you should be, okay? So that's why we have to look at the overall profile, okay? So we have to look at your distribution of HDLs and LDLs, as well as triglycerides. So this kind of puts us on a different track or a different subcategory. So we were just talking about lipidemia. Now we're getting a little more specific. We're saying, okay, we mostly care about the cholesterol. Okay, so lipids, triglycerides, we seem to be able to deal with those okay. So we're going to look at cholesterol. Too many lipids, though, will interfere with the cholesterol as well. I should just say that. So we're going to look at cholesterol for now. So we're going to look at hyper. That should say hyper. Oh, I forgot to change that before. Hypercholesterolemia. So hypercholesterolemia is a subcategory of hyperlipidemia. So now our cholesterol is elevated. And so this is where we really pretty much only focus on the HDLs and LDLs, okay? Because those are going to deal with cholesterol more than like the VLDLs and the chylomicrons, of course. Okay, so it's an increased level of cholesterol in the blood. These are numbers that you should know. Okay, so total cholesterol 200 milligrams per deciliter. LDLs, you want those to be under 100, and you want your HDLs to be over 60. Okay, so again, it's going to come down to, sure, my LDLs, my total cholesterol may be 210, but if it's mostly caused because I have an enormously high level of HDLs, that's okay. You know, you're probably, research shows that you're going to be okay. All right, so here's the graph from your book that kind of breaks it down a little more specifically, and talks about, you know, kind of puts it into categories: borderline high, 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 very high. Okay, let's see. Again, primary factors are genetic, include defective. Oh, this is actually pretty important. When we're talking about how your lipoproteins are either high or low, you can either say, oh, well, I make too many. I make way too many, and of course we're mostly worried about LDLs. So I make too many of them. So that's synthesis of apoproteins. That's why they're high, is I make too many. Or, where are these guys going? We're making them for a reason. We're making them to distribute them to cells. What if the cells, the receptors that we're saying, hey, you know, we need lipoproteins because okay, if I draw a cell here, and this is a cell that needs lipoproteins, it's going to have a little receptor here, okay? And so when this lipoprotein comes by, it has proteins on it, apoprotein 100 or something like that, that this receptor is going to recognize, and then that is going to move into the cell, and then it's going to be deconstructed, it's going to be taken apart, and everything is going to be used in it. What if we don't have those receptors? Think about this. It's very similar to what was going on with insulin and glucose transporters. Remember, that's how we get rid of glucose. It moves into cells. That's how, largely, we get rid of cholesterol or lipoproteins as they move into cells. If we don't have a receptor, this guy just keeps going, and so does the next one, and so does the next one, and they build up. Okay? So you can see that if we make more, we have a buildup in the blood. If we don't have receptors, or we have fewer receptors, I hope you understand that. If we have fewer receptors, it's also going to build up. Because there's that receptor that's supposed to say, hey, come in this way, and it's broken. Okay? Either broken, not expressed, something about it is not right. So there's a let's see, common familial cholesterolemias, xanthomas can be formed, and these are people that have so much cholesterol that it's actually forming growths or deposits on their skin or in their eyes, and that's because they're lacking LDL receptors. So I hope you understand that. I'm sure there'll be a test question kind of concerning that. Okay, and then the secondary factors are similar to what we just read about hyperlipidemia. Okay, now let's talk about atherosclerosis. First, let's define it. It is a formation of a fibrous plaque. Okay, so a fibrous plaque is going to be what we see here, a plaque. It's a buildup of something in the internal lining of the large and medium-sized arteries. Okay. So it's nice to break this down word for word. So here's a plaque that's building up, and it's in an artery, such as the aorta and its branches. So something like, you know, maybe one of the arteries going to the brain, or the brachial artery, or something like that. Usually it's pretty quickly after it leaves the heart. And its branches, the coronary arteries. Okay, so if here's our heart, then we have blood that has to, so as it's leaving the left atrium, we have blood that actually kind of goes to feed the heart. Okay, so the heart muscle needs blood too. All right, so those are our coronary arteries. Okay, so we have blood that's going, blood vessels, arteries that are going to give the heart muscle itself blood, and it needs a lot of oxygen, right? It needs a lot of nutrients because it's working all the time. It's the muscle that gets no rest. And so if you have a blockage in that, that's going to be, those are your coronary arteries, that's what causes a heart attack, okay? So all of the rest of that tissue that was being fed by that can die, okay? So then you can have necrotic tissue and it can die. Okay, so atherosclerosis affects those, and that's really where, people have a heart attack. They get this buildup, and then somehow thrombosis or thrombocytes form, clotting happens. Platelets aggregate, and you get a clot, and then you have where this black area is. That could be necrotic tissue. That's a heart attack. Cerebral arteries that supply the brain. Of course, that could be like a stroke. Where you have blockage to the brain. Okay, so I put here on one page, and I hope you study a little bit, but it's fatty streaks and atherosclerotic plaque formation. So let's just kind of go through what's happening. We have a blood vessel, okay? So here's our blood vessel, and it's got its several layers, okay? And you have these LDLs that are kind of moving through, okay, moving through the blood vessel. And what happens is if some kind of damage takes place, then these LDLs may move into the space in between, okay? And that's kind of what we're seeing here, okay? We're seeing these LDLs that kind of move down into, so they penetrate the endothelial wall and the tunica media of an artery following some kind of damage. Chronic hypertension can contribute, but so can toxins from cigarette smokes or a number of other things can also contribute. But some kind of damage must have happened, and these lipoproteins will kind of go down into the inner layers of this vessel. Okay, so they kind of penetrate through the endothelial tissue. Well, that's a problem. That's an invader. Okay, so your blood vessel will ultimately view that as an invader, and who comes along? Well, in this case, they're macrophages or monocytes. Monocytes that were moving through there will say, hey, you're not supposed to be there, and they'll try to go in and they'll try to clear that. So what they do is they eat it, okay? Essentially, they will phagocytose it, and they will eat it. And as they do that, they turn into these things called foam cells, okay? So it will kill them. It will kill the macrophage as it's trying to engulf all of these low-density lipoproteins that have moved in. And so the macrophage releases oxidizing molecules, or like free radicals. It'll release those, trying to break down those fats, and then it engulfs it, phagocytoses it to get rid of it. But they die, and the phagocytosis of that LDL converts it into something called a foam cell. Okay, and so those foam cells will kind of build up and accumulate with other foam cells, and that's really what's causing something called a fatty streak. So if you were to look at someone's blood vessels at this point, if you were to go in and see them, you could see these kind of yellowing kind of areas along the blood vessels, and that's when you know something's going on. You know that the LDLs have moved out and the macrophages have tried to do something about it. Okay, now that can last a little while, these fatty streaks. You can see that for a while, and they may, it's possible that these could be cleared as long as they don't progress, but chances are they're going to progress. So the foam cell that was formed from those macrophages releases growth factors, other inflammatory signals, and over time, more endothelial damage takes place. This is the progression of that. Now remember that medial layer, the tunica media, that had all the smooth muscle cells? Well, those smooth muscle cells will then start to kind of multiply, okay, and they'll kind of move out and surround it, okay, and they'll form, and along with like elastin, and they will form a fibrous cap. Okay? So now there's if we look up here, there's a fibrous cap of smooth muscle that's kind of surrounding what was there. And this thing can continue to grow. Okay, so some more lipoproteins will move in. Um, but it can continue to cause problems. So the smooth muscle then deposits calcium to make it sclerotic or hard. So now this becomes kind of this whole thing becomes sclerotic, which sclera means hard, um, and so that happens. Stray factors and turbulence can cause thrombocytes to collect, and you can actually get clot formation from that as well, because as we've talked about before, turbulence can cause those thrombocytes or those platelets to collect, and that can risk a clot. Okay, so this is the picture I was trying to draw, so you can kind of look at that. You can kind of see the lipoproteins move below the endothelial cells, and then they form these foam cells. That's what you see in 3 here. You see the foam cells being formed, and then the smooth muscle cell forms that cap, that fibrous cap around it. But either way, it bulges out and it gets in the way. Okay, so a couple of terms, I've already mentioned them, but fatty streaks, those occur early before the true atherosclerotic lesion forms. Okay, and these can happen, early. Children as young as 10 to 14 years old. They continue usually to increase in number, but they may become static. They may not change at all, or they may even regress. So that's not bad if you can sort of identify that early on and change your lifestyle, change your eating habits. It is possible for those to regress. Progression to atherosclerotic lesions. So these fatty streaks will progress to an atherosclerotic lesion, and that is a collection of additional lipids, proliferation of that smooth muscle. Okay, remember the smooth muscle that's kind of forming around it. Okay, and then of smooth muscle and fibrous tissue. So there's some elastin mixed in with there, and that's what's causing that fibrous tissue. And remember, those foam cells are kind of in here, kind of collecting together too. Okay, so now we have an atherosclerotic lesion or an atherosclerotic plaque. Then it can progress to a complicated atherosclerotic lesion, and that is where maybe this, oops, I didn't mean to erase all of it. So maybe this fiber or this fibrous cap isn't very thick, okay, and so it could rupture, okay, could break open, some kind of trauma or something like that could cause it to break open, and then you have the release of so the fibrous cap breaks open, forming a hemorrhage, so loss of blood, more damage to the tissue, and that's going to this could actually trigger some cell signaling. If some of these, it's not going to just pop open all of it, but it could sort of leak out. More signals could leak out, and it could actually cause more thrombocytes to form, and it could actually lead to more clot risk. Okay, so thrombosis, so that's clot risk, may occur due to turbulent flow, more vessel damage, and that's a complicated atherosclerotic lesion. Okay. All right. So plaque stability. So some plaques are stable, and they have thick fibrous caps, and so those are the ones that they even though they may continue to grow and block blood flow, they tend to be, because they have this thicker cap, they tend to be a little more stable. They still will partially block vessels, but they don't tend to form clots, okay, or emboli. Emboli is just a clot that kind of got away and went and blocked something else. Okay, unstable plaques obviously are kind of the opposite. They have a thin fibrous cap, and that's really the difference. They have a thin cap, and so they can rupture, cause a clot to form, may completely block the artery. The clot may break free, and that's what an embolism is, or an embolus. Um, okay, so these obviously are more dangerous, more emergent. Okay, so let's see. Atherosclerosis and clinical manifestations. Well, it depends. Depends on the vessel involved. But if you're talking about arteries, it's hard to find a good vessel. Okay, so they're all pretty much bad, but they tend to have different names as we have down here at the bottom. So it depends on the vessel involved. Arteries supplying the heart, brain, kidneys, lower extremities, and small intestine are most frequently involved. So none of those sound very good. So what happens? You have narrowing of the vessel. Okay, you have narrowing of the vessel because the plaque is forming, pushing out into the vessel lumen or the space. And you have ischemia, so you have a blockage. That's what ischemia is. Um, Things that the blood is supposed to be carrying have a harder time getting there. Sudden vessel obstruction, okay, caused by a hemorrhage or rupture. Could occur thrombosis, so that's a clot, and formation of emboli, that's a clot that moved away, or it's any object that kind of moved away and clogged something, but it could throw a clot, as we would say, and then it could embed somewhere else. Okay, so resulting from any kind of endothelial injury, so that could happen. An aneurysm, because what have we done? We have broken down the inner wall of this artery. Okay? And if we break down that inner wall, well, that blood pressure could push out and cause an embolism to occur, and blood could fill in there. And then if that were to pop, then this blood would rush out. Okay, so that's not good either. Okay, so by weakening the vessel wall, you could form an aneurysm, which we'll talk more about. Okay, so coronary artery disease, that's talking about the coronary arteries. Remember, in the heart, those blood vessels that are actually trying to give blood to the heart muscle. Okay, so if one of those gets blocked, then you have necrosis or infarction. That's blocked blood flow that results in tissue death. You may have an infarction or myocardial infarction, which makes sense. Myocardium is the heart muscle, and an infarction is damage caused from a lack of blood flow to it. Okay, so that's so when you're at risk of that, it's coronary artery disease. If it's the carotid arteries or arteries in the brain, you have a risk of a stroke. If it's peripheral arteries, then we call that peripheral artery disease, and that pretty much excludes coronary artery disease, the aortic arch, which comes right out of the heart, and brain arteries. So if it goes a little beyond that, we tend to call that peripheral artery disease. Okay, so vasculitis. Vasculitis is not as specific as atherosclerosis, but it's an inflammatory injury of blood vessels. Okay, so itis means inflammation, and vascular refers to blood vessels, so that kind of makes sense. May result from direct injury, infectious agents, immune processes, pretty much anything that comes down and damages or affects the vessel wall. Okay, so that's going to be a vasculitis. Could be secondary to other systemic disease states, so some other disease may result in damage to the vessel wall. Okay, so clinical manifestations, so some of the signs and symptoms: fever, myalgia or muscle pain. Okay, so if you have damage to the vessels, especially associated with muscles, muscle pain, joint pain, so arthralgia is joint pain, malaise. Okay, so these could be broken into small vessels, medium vessels, and large vessels. Okay, so we're going to talk about a couple of types of peripheral artery diseases that are seen. They're not necessarily common, but they're seen. So peripheral artery disease, atherosclerotic blockages, large arteries, not coronary or aortic. So if we have, let's see, that could, whoops, where did I go here? Okay, peripheral artery disease. Of course, remember that's peripheral artery diseases are not coronary not the coronary artery, not the aortic arch, not the brain. So thromborangitis, obliterans, or Berger's disease, this is actually a non-atherosclerotic inflammation and thrombosis. Okay, so this is not caused by this is not a peripheral artery disease because it's not atherosclerotic. But it affects small and medium-sized arteries and veins. Okay, and specifically what we're talking about is we're talking about something that occurs in the extremities, and you can see here tends to be you can see that it tends to affect the hands. Okay, so it can cause thrombosis, which means you have a buildup of clotting factors. So clots form in small, medium-sized arteries, which means that you're blocking blood flow. You're blocking blood flow to those. Okay. It's seen in young, heavy cigarette smokers, maybe a mass, some kind of other clotting disorder that's mass. We're not sure really what causes it, but we know what it's correlated with. So it's correlated with this young, heavy cigarette smokers, and its thrombosis is usually involved. Okay, so it's the formation of clots, and but what's actually causing it and the mechanism, we don't really know. We just know what it is. So pain, distal arterial ischemia. So that means that you've got blockage and you're going to feel pain from it. Okay, there's something else called Raynaud's syndrome. Intense vasospasm. So whereas this one, the Berger's disease, was clotting, this one is a vasospasm. Okay, so that means that the blood vessels are spasming or constricting and blocking blood flow. So it's arteries, arterioles in the fingers and toes, and you can see here kind of in the picture where you can see whiteness or pallor in the fingertips. Okay, so you've blocked blood flow. Pallor, numbness, sensation of cold, precipitated by cold or strong emotions. And the cause of this also is unknown, but it's something that's going to, for some reason, vasoconstriction is, or vasospasm, which is a vasoconstriction, is going to reduce blood flow to those. Okay, so this is important. Aneurysms. Everybody needs to know what aneurysms are. It's a local dilation or outpouching of a vessel wall or cardiac chamber. So what does that mean? That means you normally have a blood vessel that is just fine, okay? But then at some point you have a weakening. Now, if the weakening only happens on one side or on the inner layer, then we call that a false aneurysm. And you can see something like you see in that first picture where it just sort of bursts out like that. Okay. Now, if it happens, if it's a weakening that's more, I guess, consistent with both sides, so you have a weakening here and here, then it's going to push out on both sides, and that's going to be a true aneurysm. Okay. So false aneurysm, dissection or tear of the inner wall, often from surgery or trauma, and that's where you see this, like a saccular aneurysm. True aneurysm bound by a complete vessel wall, but it's still going to be a weakening, right? I mean, the vessel wall still must be weakening for some reason, and that's where you see fusiform aneurysm, circumferential aneurysm, something that's a little more, so it's bulging out. You can see all the way around rather than just in one area where there may have been damage. Okay, so aneurysms are, yeah, that's the problem, risk of rupture. I mean, if you have kind of this bulging out area and then it breaks, well, that's going to be a pretty severe bleed. If it happens in the brain, that's a very, very difficult thing to treat. Okay, so risk of rupture and hemorrhage, risk of clot formation following that, or actually as part of the aneurysm. So you can see here in the circle of Willis. Okay, so that goes up into the brain, and you have this network of blood vessels that sort of form this thing called the circle of Willis. But that's not necessarily so that a lot of times aneurysms happen actually in this area. And you can see one, a berry aneurysm. Okay, so it sort of looks like a berry. That's why it's called a berry aneurysm. And so you see that that would be a weakening of the wall, and then it sort of pushes out. Fusiform aneurysm, so we saw that on the other page too, and so it's kind of pushing out on both sides. And a saccular aneurysm is also sort of forming a sac that kind of moves out like that. Okay. All right. So common in the aorta. So aneurysms. That's actually where you see a lot of aneurysms, namely in aortic dissection. You see a lot of aneurysms actually occur in the brain, particularly, like I said, in the circle of Willis, which is where these blood vessels are kind of all coming together to enter the brain, or as they get into the brain. Okay, and of course the greatest threat again is rupture. So an aortic dissection is not like dissecting like you're dissecting a frog or something like that, but it's a breach of the inner wall of the aorta. Okay, so the aorta, of course, we've already talked about the different walls, like the tunica interna, media externa. So if you have a breach of this internal wall, what can happen is blood will then move out and it will kind of occupy that space. And if it occupies that space, it can form clots. It further can weaken this wall. And so this is obviously a weak point here. So blood has moved in. It could so that could actually blow out. And if that blows out, there's really not much you can do unless you're right there when it happens, because the blood is going to leak into the mediastinum, and that's going to be just a mess. Okay, so an aortic dissection, breach of the inner wall of the aorta, creating what's called a false lumen. A lumen is just an opening, and so blood moves out into this area as well. Okay, so it's acute. It's an acute life-threatening condition. Involves hemorrhage into the vessel wall with longitudinal tearing or separation of the vessel wall to fill a blood to form a blood-filled channel here. That's what we see here. Okay, caused by conditions that weaken or cause degenerative changes in the elastic and smooth muscle layers. Risk factors: hypertension, so high blood pressure when blood is pushing through there and there's a lot of resistance. Degeneration of the medial layer of the vessel wall, connective tissue diseases. Okay, so any kind of connective tissue, because these vessel walls remain strong because they have good connective tissue. If you have a genetic disease that reduces your strength of the connective tissue, then that could cause it. Congenital defects of the aortic valve. Okay, so anything that's going to increase the pressure that's in here, or something like that. So clinical manifestations: abrupt, excruciating pain, tearing, ripping. That sounds horrible, but it kind of makes sense because that's kind of what's happening. Blood pressure is initially elevated and later may become unobtainable in one or both arms when this occurs. Now you can surgically go in and you can they've figured out ways to repair this if you catch it before it bursts or before it forms a clot or something like that. Okay, or before it forms a clot that gets thrown or forms an embolus. Okay, so arterial blood pressure. We've been kind of talking about it, but blood pressure is obviously a problem with people. So when we're talking about blood pressure in the arteries, obviously we're leaving the ventricle, moving into the aorta, because we're talking about systemic. That's where we care about it the most. And so it moves into the aorta and it pushes out on the aorta. The determinants: cardiac output. We've already defined this in a different set of slides. Stroke volume, which is how much the left ventricle squeezes out, times heart rate. We know what heart rate is. Okay, so how much blood are we actually producing? And so yeah, that's going to have an effect on blood pressure, obviously. Now, Peripheral vascular resistance. So this has to do with things like atherosclerosis or arteriosclerosis, which is where the blood vessels are hardening from normal aging. And so you can have this increased resistance, and that will increase or decrease your cardiac output because your heart isn't able to push as much blood through there. So systolic blood pressure, ventricular contraction. Okay. Specifically, when we're talking about measuring blood pressure, we're talking about left ventricle. So left ventricle contraction, so ejection of blood from the left ventricle to the aorta, and this is going to be primarily influenced by stroke volume. Okay. So stroke volume is how much blood is pushed out. Diastolic pressure is what happens after, so as the blood is pushed into the aorta and that semilunar valve is pushed closed, then this blood has no other place to go but forward. Okay, so the more easily, I hope this makes sense, the more easily that blood moves forward through the cardiovascular system, then the more that aorta in this case is going to be able to get smaller. Okay, if there's a lot of resistance, then that pressure in the aorta is going to be sustained. Okay, so if it just flows right out, if your blood vessels are so clear that it just flows right out, then this will move in quite a bit. Okay, now if it doesn't, if there's a lot of resistance, then this isn't going to move in as much at all. Okay, so that means your diastolic, or when your ventricle is at rest, your diastolic blood pressure, if you have a lot of resistance, is going to be higher. Okay, because it's not able to push that blood through as much as it wants to. Okay, so ventricular relaxation and filling, primarily influenced by vascular resistance, as I've said about 3 or 4 times. Okay, a couple of other terms. Pulse pressure. Pulse pressure is the difference between the systolic and the diastolic pressure. Systolic pressure is ventricular contraction. Diastolic is ventricular relaxation. So that pressure difference when it goes up and then it goes down, and you've got this maintenance of pressure, systolic, diastolic, and that difference here is going to be your pulse pressure. Okay, so you can also see that there. Arterial inflow, so flow into the arteries, exceeds arterial outflow during systole. That means that it's not moving through. Let's see, pulse pressure reflects a difference. Or it is moving through. Increased pulse pressure reflects increased cardiac output. Well, that kind of makes sense. You have more blood being pumped by the heart, then that's going to kind of increase that top level. Or decreased resistance. So it could be that we have more, so that means that your blood pressure is going to be a little bit of, let's see, so decreased PVR. So decreased PVR is going to increase your pulse pressure, right? Okay, so if we have, so then the opposite is going to be true. If we're going to have decreased pulse pressure reflects a decreased cardiac output and or an increased PVR. Okay, let's see. So then mean arterial pressure, or MAP. So your mean arterial pressure is going to be between the systolic and the diastolic. So your systolic pressure is that squeezing of the left ventricle. Your diastolic is going to be the relaxation. And so since we spend more time in relaxation or we spend more time in diastole than systole, then that's actually going to be a little bit lower. So if this is systole, this is diastole, then it's going to actually be sort of down here a little bit more. Now we can calculate that, but we're only approximating it because it really depends on your stroke volume, cardiac output, and that's not just measurable by pressure. You actually have to measure the volume. But since we can measure the pressure, then we can kind of get a pretty good guess as to where we sit on that. Okay, let's see. All right. Okay, so regulation of blood pressure. Um, there's short term versus long term, and your book kind of separates them that way. I won't do that like on an exam. I won't say this is short term or this is long term. I mean, I may refer to short term, but I'm more interested in you knowing what they are, because a lot of times some of these that are kind of up here, like the renin and vasopressin, a lot of times in some books these will actually be considered long term regulation. So we're talking about regulating blood pressure, increasing, decreasing to kind of to keep it in a healthy range as much as possible. So short-term regulation, neural mechanisms. Okay, so that means your brain can turn well, I guess it can turn your blood pressure up or down. So it can either increase cardiac output, it can increase heart rate, um, contractility, it can increase vasodilation, vasoconstriction, those types of things. So you do have control over that. It's done with the autonomic nervous system, which is, remember, the sympathetic and parasympathetic make up the autonomic nervous system. And so intrinsic reflexes means that you're measuring it from the inside. Okay, so that means you're actually measuring the blood pressure, or the content of the blood. So baroreceptors can measure how much your blood vessel is being stretched. Okay, so if it's being stretched a lot, then those baroreceptors will measure that, and they'll say, okay, well, we have high blood pressure, so maybe we want to activate the parasympathetic nervous system to decrease heart rate. Okay, so chemoreceptors are going to measure like oxygen, so O2 levels, CO2 levels, hydrogen levels, those types of things. Extrinsic means that that's something that's happening from the outside. So pain and cold, those can also have an effect on blood pressure. The humoral mechanisms, humoral referring to fluid, the renin-angiotensin pathway, we'll talk a little bit about that, and vasopressin, which is going to be how much water you retain in your body. So it's going to, both of these actually will have an effect on fluid volumes overall. And then long-term regulation, well, the kidneys in general are controlling how much fluid is in your body. And, it's controlling how much salt is in your body. And so that can cause a long-term effect, okay? And thirst. If you get more thirsty, you're going to increase fluid volume. So in most tissues, blood flow is proportional to the metabolic needs of the tissues. I hope that makes sense. That means that the more stuff your cells need, the more they're going to expect more blood, okay? And that's going to be controlled by the cardiovascular system, or the cardiovascular system is going to ultimately provide it with that blood. Okay, so nervous system control, again, responsible for routing blood flow and maintaining blood pressure. Hormonal control, okay, so we have hormones that can affect it, and this is kind of related. So the epinephrine and norepinephrine are kind of related to what we saw up here with neuromechanisms. Okay? So these are related. If you have epinephrine, another word for that is adrenaline, so that's going to be part of your autonomic nervous system and your fight or flight, so the sympathetic division. So that can cause vasoconstriction or vasodilation. It really depends. It might vasodilate to the skeletal muscle, vasoconstrict to the gut region. Okay, so these are some of the controls. So let's kind of narrow this down and be a little bit more specific. That's probably more helpful. So short-term mechanism, autonomic nervous system control. So what do we need to know really about that? We need to know that there are baroreceptors. Baro, like a barometer. A barometer measures like air pressure. That's a weather thing. So it's measuring pressure. So a baroreceptor in your body is going to measure blood pressure, and it does that by measuring how much it's stretched. It will result in, okay, so when it measures, when it realizes that you have either, well, it usually is activated by stretch, so the more blood pressure, it will result in a change in vessel diameter. So it may cause some vasodilation, it may reduce your heart rate and stroke volume. And so that's going to reduce your blood pressure. Chemoreceptors measure carbon dioxide. And remember, carbon dioxide, as your carbon dioxide increases, your pH decreases, and how these things affect how much. Well, okay. So carbon dioxide directly relates to nutrients of the cells. I mean, if you have too much carbon dioxide, you need to get rid of that. And so that's going to, yes, it's going to increase your breathing rate, but it's also going to increase how much blood is flowing through. We need to cycle that through, and we need to get rid of it. If your oxygen levels are low, same thing. That means we need to increase blood flow. I hope that makes sense, because it's a huge compensatory issue. Like someone with COPD or someone with a lung disease that can't get enough oxygen, well, their only compensation is to take the blood that you have and just cycle it through the lungs as much as possible. Um, okay, so, and hydrogen, same thing. That's an indicator. That's an indicator that your carbon dioxide has changed, which is going to have an effect on hydrogen levels, and so that too is going to change the whether it's up or down, change whether or not you want to move blood through more quickly or less quickly. Okay, and so these pictures, I'm not too worried about the details of that, but that just sort of shows how you have these receptors that are in various places, and they're constantly measuring either stretch or they're measuring the content, the chemical content of the blood. Okay, to affect your blood pressure and blood flow. Okay, so other short term, so yeah, like I said, this is considered short term. In some cases, it can be considered long term, but these are humoral. In humoral, we're talking about the fluid. We're talking about fluid control. So, or something floating around in fluid. So the renin-angiotensin-aldosterone pathway. So renin is released from the kidneys, and it turns this other molecule that's floating around angiotensin into angiotensin 1, and then there's angiotensin converting enzyme that turns it into angiotensin 2, and angiotensin 2 has a lot of effects, okay? And a couple of those, one important effect that angiotensin has is that it will cause the release of aldosterone, okay? I know this sounds complicated, and honestly, you learned this pathway in physiology, and I really don't feel like teaching it again, and so that's why I'm going through it very, very quickly. I won't ask you a lot of details, but the thing you have to really understand is this pathway, this renin-angiotensin-aldosterone pathway, really activates a lot of things and has a lot of effects. So aldosterone is going to affect sodium reabsorption in the kidney. Angiotensin 2 itself can affect things like cardiac output, sympathetic activation of blood vessels, so it's going to cause vasodilation, um, increased thirst. So there are a lot of things that result from this first renin-angiotensin-aldosterone pathway. But when this mechanism, and this is what you really, really, really need to know, when this mechanism is activated, it is going to result in an increase in blood pressure. And you also need to know that it's doing it through a number of mechanisms, okay? It's not just one thing that's happening. It's a number of different things. Okay, so the other one in terms of humoral mechanisms results is vasopressin. Vasopressin, also called antidiuretic hormone. Okay, so this is one of the two that are released from the posterior pituitary. So vasopressin, when it's released, it results in the reabsorption of water. Okay, so if something was going to move through and become urine, then when vasopressin is released, it increases these things called aquaporins, and then water will move back into the body. If water is moving back into the body, what's that going to do to blood pressure? It's going to increase it, okay? So both of these mechanisms will lead to an increase in blood pressure. And there are plenty of drugs that work on both of these mechanisms, specifically something like a diuretic, but they will work on both of these mechanisms to decrease, to block them, which would lead to a decrease in blood pressure. Okay, so they're both activated in response to lower blood pressure, circulating volume, extracellular sodium level. Okay, so they're activated or triggered in response to low blood pressure, something associated with that. Okay, so long-term regulation, again, fluid volume is directly related to blood pressure, has a direct effect on cardiac output. Okay, so more blood, more cardiac output. Indirect effect on peripheral vascular resistance, so the resistance is changed. So yeah, so that could increase that. So fluid volume is primarily controlled by the kidneys. We've already mentioned that. Blood volume can be controlled by urine output. So the more urine you produce, then the lower the fluid volume, and so the lower the pressure. High salt levels, you're going to retain water more. Okay, so that's why we tend to want to stay. If you have a heart patient, you want to reduce salt levels, because that's going to cause an increase in water retention, which is going to be an increase in blood pressure. Okay, so renal disease, this is kind of an important point here, and I'm sure something that's going to come up in some kind of a sideways way in the exam, but renal disease is the single largest cause of hypertension, okay? And it's because of these things. It's because the kidneys are controlling fluid volume, okay? Okay, it's also where renin is released, which is going to cause an increase in blood pressure. Okay, so which we just learned. Okay, so hypertension. So hypertension is a persistent elevation of blood pressure. Okay, so primary hypertension, essential or idiopathic hypertension. It's genetic, or so either we don't know what causes it. It's genetic, or it could be caused by environmental factors, and this consists of 90% of people with hypertension. We either don't know what it's caused, it's genetic, or something environmental. Secondary hypertension caused by a systemic disease process that raises peripheral vascular resistance, raises PVR or cardiac output, and this is usually a renal problem. Okay, so that's what we just mentioned. Secondary hypertension is usually some kind of a renal problem, which doesn't allow your blood pressure to be regulated properly. Okay, because a lot of blood pressure regulation happens in the kidneys. Okay, so diagnostic criteria and treatment determined by repeated blood pressure measurements. You can't just take somebody's blood pressure once and say, "Holy cow, you're in big trouble." You kind of have to see what happens over time. Okay, it's based on the average of at least 2 or more blood pressure readings taken at each of 2 or more visits. Okay, after an initial screening visit. Okay, so we want to make sure that it's not a fluke, and that it's persistent, because that's part of the definition, part of the diagnosis. Okay, so accuracy of blood pressure measurement, obviously you have to have somebody that's trained to do it. You have to have good equipment, and you have to have the appropriate sized cuff. Now we can see down here, this is a table from your book, and so for normal blood pressure is anything below 120 systolic and below 80 diastolic. Anything above that is either pre-hypertensive, stage 1 or stage 2 hypertensive. Now we can also get into something that we'll talk about in a second, which is hypertensive crisis, and you'll have to know those numbers as well. Okay, so risk factors, primary hypertension. Constitutional. So when we use the word constitutional, we're really talking about something that is of you or what makes you you. So your family history, your age, so there's not much you can do about that, your gender, your ethnicity, glucose intolerance or insulin resistance, that's considered here too, because that's usually something that's just sort of not really under your control once it takes place. Now, there are some things that are associated with lifestyle that you can control, things like cigarette smoking. Obesity, that's a tough one because obesity and weight in general is largely genetically determined, but it is something on some level that we have a control over. Heavy alcohol consumption, true, we have a control over that. So sodium intake of other nutrients as well, like potassium, calcium, magnesium. Okay, so hypertensive crisis, blood pressure with diastolic values greater than 120, or um, or systolic greater than 180 with a diastolic of greater than 110. Okay, so what hypertensive crisis is. Um, if you can sort of imagine blood pressure, and we've already sort of talked about cells, and if we talk about things like neurons that are trying to function in the brain, we can sort of see that an increase in blood pressure is going to increase that hydrostatic pressure, and you're going to have fluid movement. You could have damage to the blood vessels, and that could actually cause a lot of problems. So it's an emergency when blood pressure shows signs of end organ damage or mental status changes, maybe breathing issues. So the target organs tend to be where it really causes a problem, obviously in the brain and the heart. Large vessels, kidney, can lead to hypertensive encephalopathy, which is kind of what I was describing here, cerebral edema, and that's where you've got such high blood pressure in the brain that the fluid is moving through, and you actually have swelling, and that can interfere with neuronal function, which can lead to seizures and coma. Okay, so hypertension during pregnancy. We call that preeclampsia. Okay, so an increase in blood pressure during pregnancy. Now, when that results in seizures, we call that eclampsia. Okay, so preeclampsia, eclampsia, pregnancy-specific syndrome, a placenta is required. So the mom's blood supply is going through the placenta. So as the placenta tends to develop, then there's more blood being moved away from mom through the placenta and to be shared with the baby. So what that does is it kind of opens up this potential for blood to suddenly be constricted to the placenta or reduced in some other way. But either way, blood being shunted away from the placenta is going to lead to higher blood pressure in mom. Okay, so here's this large organ that has a lot of blood in it, and suddenly you've reduced blood flow to the placenta, and it can lead to an increase in blood pressure in mom. So preeclampsia, BP, blood pressure of greater than 140 or greater than 90, that's present and observable. I think that's supposed to be systolic, diastolic. That is present and observable after the 20th week of pregnancy. Okay, so again, that goes to the placenta when it's developing, and then it can actually have an effect. And it's accompanied by proteinuria, so that means that there's protein in the urine. So that's how you would sort of diagnose this. Eclampsia, like I mentioned, eclampsia is the occurrence of seizures in a woman with preeclampsia that cannot be attributed to any other causes. Okay, so there's also something called gestational hypertension, which is elevated blood pressure, but it doesn't have the proteinuria. Okay, so it's detected for the first time during mid-pregnancy, and that usually returns to normal by 12 weeks postpartum. So a few months after the baby's born, that tends to go back down. Okay, so the last thing we're going to talk about, veins and varicosities. We kind of mentioned that in the last slide when we were talking about blood flow and blood vessels. So a varicosity is usually somehow related to valve damage. Okay, and so this can be a serious collection of blood in the veins, usually in the legs. So trauma to the saphenous vein that damages one or more valves, gradual venous distension caused by standing for long periods, and the pull of gravity. Okay, so this is where you kind of have blood flow is backing up into this area, and it can cause, and so you can actually see this from the outside. You can see kind of uh, this bulging out of some of these veins, and so so ultimately the pressure in the vein can damage the valves. You're unable to maintain a normal venous pressure, and so you have venous pooling, because remember, those valves are helping move that blood flow through. And so now you're dependent kind of on pushing it via the hydrostatic pressure. And if these valves are stenotic, or these valves are not working properly or damaged, then you will have just a huge amount of pressure and distension. These will stretch and take on all of that blood. Okay, so hydrostatic pressure increases, further distending the vein, and edema develops in the extremity. Okay, so that's a varicosity. We also hear about things like spider veins, which is less of a that's more superficial, and you can kind of see spider veins. You'll see those on the more on the surface. This is a little more serious than that. Okay, so chronic venous insufficiency. So this is where the veins aren't necessarily closing well, so you may have pooling of blood through that as well. So causes pathological changes as a result of ischemia in the vasculature, skin, and supporting tissues. Causes most common is deep vein thrombosis, which causes incompetent valves and pooling. Okay, so muscle pumps are also ineffective. So this is what a muscle pump looks like. When the muscles squeeze, pushes blood up, and then when they relax again, it closes those valves. So chronic pooling of blood in the veins of the lower extremities, hyperpigmentation of the feet and ankles, edema of the lower extremities, and may extend to the knees. So complication, venous status, ulcers, and infection. Okay, so the last thing, for real, I mean at this time, I've been mentioning these words: a thrombus, which is a clot, versus an embolus, which is a clot that's thrown. So technically, a thrombus is a blood clot that remains attached to the vessel wall. An embolus is a bolus of matter that is circulating in the bloodstream. I use them together because oftentimes a thrombus that is formed in one place may end up detaching and moving to a different place, which would be an embolism. So a thrombus can be arterial thrombi or venous thrombi. An embolism can be a dislodged thrombus, which is what I've been referring to, but, and this is important, it can also be something like an air bubble, okay? An air embolism, amniotic fluid, aggregation of fat, okay? So a fat aggregate that breaks off, bacteria, cancer cells, anything that can get in, any kind of a foreign substance, anything that is thrown into the circulation and then results in some kind of a clot. Okay, that's an embolism. Okay, thrombi are more specific to things like platelet aggregation or something like that. Okay, so arterial and venous thrombi. Arterial, most common cause, roughening of the tunica intima by atherosclerosis. Okay, so that's going to result in a thrombus. You might have arterial occlusion. Angina is pain caused from some kind of ischemia that could be from a thrombus that was thrown. Okay, so if that makes any sense. Angina, we're usually talking about pain in the chest, and so if you have a thrombus that causes a partial blockage, then you may experience pain. Venous, most common cause is thrombophlebitis or an inflammation, and you have obstructed venous draining. Okay, and then you have pooling, which is going to lead to some usually lower extremity edema. Okay. Is a clot, okay, so here's this question. We've already addressed this in other lectures, but is a clot dislodged from a leg vein? Is a clot dislodged from a leg vein more likely to cause a stroke or a pulmonary embolism? Well, if it's dislodged from a leg vein, well, if it's from a vein, its next stop is the right ventricle or the right atrium. From the right atrium to the right ventricle, from the right ventricle, it's going to the lungs. Okay, so if you just sort of trace the pathway from the leg and then back up to the right side of the heart, okay, and then to the lungs. Okay, so it's going to be more likely to cause a pulmonary embolism. Okay, all right. Well, I think that's the last slide. Sorry if I kind of fell apart there at the end, but that's it for this section.